Hi, everybody. Good morning. Good morning. I'm very pleased to welcome you today to our webinar, Taking Global Action Toward Improved Care, Quality of Life, and Empowerment for Older People Living with HIV. So this webinar is being hosted today by the founding organizational members of iCOPE HIV, the International Coalition of Older People with HIV. We'll be introducing ourselves one by one as we go through the webinar, so I won't take any time to do that right now. And my name is Kate Merzin. I'm the National Program Manager at Realize, which is a Canadian nonprofit organization. And I will tell you a bit more about Realize as we move forward as well. I'm joining you today from Ontario, Canada, which is the traditional territory of the Wendat, the Anishinaabe, the Haudenosaunee, the Métis, and the Mississaugas of the Credit First Nation. So just a few Zoom housekeeping items before we get started. You've all come into the webinar today on mute. We ask that you keep your microphones on mute until we reach the interactive portion of the day. Just a heads up, you will have gotten a message that the webinar is being recorded. So that we can share it with folks in the Pacific regions who it's the middle of the night for right now and they're not able to be with us live. Please use the chat function throughout the meeting to share your ideas and feedback. So if you have comments, questions, ideas, things that you want people to know about that are going on in your region, please feel free all throughout to enter that information into the chat box. We'll be keeping a record of the chat so that we can have that as part of the meeting record and report afterwards. We will be engaging you in some polls later on in the meeting that will allow us to gather some input quickly from a lot of people at once. And we'll share the results of those polls in real time. And if you'd like to speak during the interactive portion of the webinar, I do ask that you raise your hand, which you do by accessing the button in your Zoom menu called Reactions, and then you choose Raise Hand if you would like to do that. For technical help during the webinar, please send a chat message directly to Janet London. Or if you cannot reach Janet for some reason, she's busy assisting someone, you can also message Roger Musselman. So without further ado, I'm going to turn over the hosting duties for today's webinar to Jules Levin, who will introduce himself and get us started with the content. Jules.
Hello, everybody. Welcome to our global webinar on aging and HIV. I'm the Executive Director and founder of NATAP, the National AIDS Treatment Advocacy Project. That's our website address. I urge you or recommend you using our website. We have a dedicated section on aging and HIV with lots of information and education and a focus on policy. It's been there for many, many years. I'm HIV positive for about 40 years. I'm 73 years old, and I am indeed living with being elderly and having HIV. So today's agenda, our agenda for today's session is to introduce you to iCOPE's HIV founding organizational members. I will start by providing a brief overview of the impact of HIV on older people according to the research. We will briefly reacquaint you with the Glasgow Manifesto. We and our guests from all over the world will provide regional snapshots highlighting key issues facing older people living with HIV and strategies being used to address these issues or not in different settings. And we will share with you iCOPE's HIV proposed vision and priorities, and then engage you in some polling questions and facilitate a discussion to gather your feedback on where we should go next. So the impact of HIV on older people. The number of people living with HIV who are over 50 is increasing globally. And I draw your attention to the lines on this graph showing highlighting different regions from all over the country. The top line in blue is Asia and the Pacific. And the lines below are Latin America and the Caribbean, Sub-Saharan Africa, Eastern Europe and Central Asia, Middle East and North Africa, and Western and Central Europe and North America. Globally, there were 5.7 million people living with HIV over 50 in 2016. The proportion over 50 increased substantially from 8% to 16%. It doubled from 2000 to 2016, and it was expected to be 21% by 2020. In 2016, 80% were living in low and middle income countries, showing the disparity between high income and low income countries. While the proportion of people living with HIV over 50 was greater in higher income countries, lower and middle income countries have higher numbers of people living with HIV over 50 that are expected to increase. From 2000 to 2016, proportions doubled in Eastern and Southern Africa, Eastern Europe, Central Asia, Western and Central Europe, and North America, tripled in Latin America and the Caribbean, and quadrupled in Asia and the Pacific regions. And here you see starkly the difference between low and middle income countries versus high income countries in terms of the number of people, not the proportion, but the number. Between 2000 and 2016, the proportion of people living with HIV over 50 in low and middle income countries increased from 7 to 14%, compared with an increase from 15% to 33% in high income countries over the same time period. Between 2000 and 2016, the number of people living with HIV over 50 in low and middle income countries increased from 1.8 million to 4.5 million, and it was estimated it would reach 6.5 million by 2020. And 80%, again, of people living with HIV over 50 in 2016 lived in low and middle income countries. Here you see a graphic description of what it's like to live with being older or elderly. In the United States, the CDC defines elderly as being over 65 and older as being over 50. And that's how I will use the terms. So being elderly, people who are elderly with HIV suffer worse, many of these syndromes, than people over 50 in general. But this is what older people and elderly people are facing. And it's really a host of so many problems, including psychiatric and mental and nutritional problems in terms of diet and eating proper diets. These are all the challenges that we all face who are older, and particularly elderly people living with HIV. We face lots of stigma and isolation, and it's not just stigma of having HIV, but older and elderly people also face internal and external stigma from being older and elderly. From the outside world, we face internal stigma that we have from within ourselves that we have, and also from providers and the healthcare system who stigmatize elderly people with HIV in particular. Many of us experience wear and tear and chronic pain, neuropathy, and severe exhaustion and fatigue. We experience comorbidities Now, a comorbidity is a morbidity is a health condition. Heart disease is a morbidity. A comorbidity is when you have two or more of these morbidities. So HIV is a morbidity. Heart disease is a comorbidity. And people with HIV have multiple comorbidities. We face polypharmacy. Some of us are taking as many as 16 medications every day. And many of us are facing aging-related syndromes, so-called geriatric syndromes. And many of us have trouble sleeping. We experience PTSD. We experience cognitive decline, cognitive impairment. We experience higher rates of depression and anxiety compared to people without HIV and compared to younger people with HIV. And many people are experiencing problems with chemical dependency, using illicit drugs. And a lot of people who are elderly have gone back to drug use because they're having so much trouble dealing with being elderly with HIV. And of course, housing and transportation are challenges for many people who are elderly, facing frailty and challenges with functioning, daily functioning. And many of us experience fear for the future. We're lonely. We feel guilt for the situation we're in. We feel abandoned by the healthcare system and our peers. And we have an aimlessness about us. And all put together, a gigantic psychosocial condition and a health and well-being condition. I want to highlight this to you and point out the health conditions that we face to draw your attention to what it means for the health conditions. And so I use this table to highlight the conditions that we face. And so I'll take note of the bars in the graphs on the right. In gray, you will see from 2013, and in red from early years in 2003. And you see after, in the later years, the rates of comorbidities increasing. And that's due to age. As people are aging, they're increasing much higher rates of comorbidities. And you see it's divided into commercial, Medicaid, and Medicare. So people who are over 65, that's people on Medicare. People who have low income, that's Medicaid. And people who have commercial insurance, that's people who have more income. And you see the rates of comorbidities in the tables. You see cardiovascular disease and compare it to the commercial payers on the top to the Medicare payers on the bottom. And that starkly shows you the increase from 2.8% to 16% as you age. The rates of heart disease almost increase eightfold. And the same thing with renal or kidney impairment. You see on the bottom, Medicare people who are over 65, renal impairment, kidney disease is 20%, compared to commercial and Medicaid, it's 5 or 10%. The same thing with hypertension, it's 65% for people who are over 65 versus much lower rates for younger and people in different insurance. And the same thing with diabetes. You see 30% for people on Medicare over 65 with diabetes. And the last column is hyperlipidemia, that's elevated lipids like cholesterol, which are risk factors for heart disease. And what's not here is the spectrum of liver disease. People with HIV experience higher rates of a spectrum of liver disease that includes hepatitis C, hepatitis B, and non-viral hepatitis, which means they don't have C or B, but they have liver disease. And that includes NASH, also called fatty liver. This study that was presented at CROI from a very large healthcare system in the United States a couple of years ago called Kaiser Permanente, which is a healthcare system all over the US, reported that people with HIV have earlier onset of comorbidities. That's what people with HIV experience. We experience earlier onset, premature aging of comorbidities. And I'll draw your attention. You see the 6 boxes. Each one is a different disease. So each one in the lines with the orange bars shows you people with HIV and what they got in this study, at what age they got liver disease, kidney disease, lung disease, diabetes, cancer, and cardiovascular disease. And the line on top, the line in a with darker circles, is people without HIV. And in each case, you can see, for example, on the upper left, say liver disease, people with HIV contracted it 24 years earlier than people without HIV. The next panel over is chronic kidney disease. People with HIV contracted it 16 years earlier. Chronic lung disease, people with HIV contracted it 15 years earlier. Diabetes, people with HIV experienced that 7 years earlier. Cancer, people with HIV contracted cancers 10 years earlier than people without HIV. And cardiovascular or heart disease, people with HIV contracted it 9 years earlier. That's what we call premature aging. Some people call it accelerated aging or accentuated aging. However you call it, it's premature onset for comorbidities, earlier onset. This was also a different study presented at the big CROI conference a couple of years ago, and I draw your attention to the bars and the graphs in red showing that people on the left, 50 to 60, in the middle, 60 to 70, and people over 70 in red are people, the prevalence, the expected increases in numbers of people who will have 2 or more comorbidities. And as you see, as time goes by over the next 10 years, we expect very significant increases in the number of people who will have 2 or more comorbidities. And on an individual basis, more and more people will be contracting increasing numbers of comorbidities in general. And the overall system of healthcare system will be increasingly burdened. So from that same study from Kaiser Permanente, they reported this data too, which was also published in a major journal, showing that people with HIV experienced 9 years less survival. In other words, on average, they died 9 years earlier. So it's a mismessage to say that people who are aging with HIV have similar life expectancy. This study clearly shows 9 years difference between the general population dying on average at 86 versus people with HIV dying on average at 77. And for people who started ARTs with over 500 CD4s, which is not the majority of us who have low nadir CD4s, started our ARTs at 100 or 200 CD4s. But for those who started with over 500, there was still a 6-year gap. So with that, I want to introduce you to Axel, and he will discuss with you his experience and issues affecting people, older people with HIV from his perspective, and he's coming to you from Brussels in Western Europe.
Hello, everybody. Yes, I'm a person living with HIV since 34 years. I've been now 63. I came, in fact, from the medical world, the medical industry. And 7 years ago, I decided to focus on HIV and try to develop projects in Belgium, mostly in collaboration with the other HIV associations. And we developed, for example, annual day on which we called Positive Health HIV, meaning all the different facets, parts of health. Just like Jules was saying, there is a mental aspect, there is a social aspect, a physical, a sexual, and that's that we try to develop in Belgium. I work very closely with the healthcare professionals, also in developing symposia. And step by step, the topic HIV and aging is starting to be considered on a right level in Belgium. A lot has still to be developed, but I'm quite positive that we are in a good trend. And I hope also with this initiative here that we will go more and more in pushing the policymakers to improve the model of care. Because as a person with living with HIV, even in a rich country like Belgium, I face problems of coordination between the healthcare professionals. I have quite a lot of different comorbidities, and it's not easy at all. I have a healthcare background, but I can imagine those without will have even more difficulties to find their way to the needed specialist. That's in a nutshell what I would like to bring over. And I give the word back to Kate.
Hello, everybody. I'm Kate Merzin. I'm the National Program Manager at Realize, which is a charitable organization in Canada that's dedicated to fostering optimal well-being for people living with HIV and other episodic disabilities. One of our pillars of focus is on HIV and aging, and we are the national lead in Canada on the topic of HIV, aging, and older adulthood. So that is where I focus most of my time. I'm also Realize serves as the Secretariat for the National Coordinating Committee on HIV and Aging, which is stakeholders from researchers to frontline service providers to people with lived experience who come together to share conversations around research, policy, education, and practice related to improving life for people who are aging with HIV. That's me.
And now we'd like to introduce Anton.
Hello, everybody. My name is Anton Basenko. I'm Ukrainian and originally from Kiev, and using this opportunity and these days, I would like to say thank you to all of you, all people, all governments, all countries who supports today Ukraine and Ukrainian people in this terrible war with Russia. I'm a person living with HIV 20 years, relatively small amount in comparison with the previous speakers, but I also I'm also a person who used drugs more than 20 years. So I represent different communities, and that's why I would like to specifically focus our further discussions on not only older or elderly term, which Jules used, but also people aging with HIV, because in my 43, I'm still on my way to 50 plus or 60 plus or 70 plus. Yeah, and that's why that's my expectation. I'm now based in Belgium and working for European AIDS Treatment Group as a program manager of the program named Quality of Life. It's quality of life of people living with or affected by HIV. But being a community activist and advocate for many years, I'm a chair of the board of International Network of People Who Use Drugs, founder of Ukrainian Network of People Who Use Drugs, and also some of you can know me from communities delegation in the board of the Global Fund or my other involvements. I have a master's degree in international economy, also have lived experience with hepatitis C. and I'm one of the first opioid substitution therapy patients in Ukraine. So I really wish you all inspiration and good luck in our event. And just a few words about European AIDS Treatment Group, which is I think it's the oldest patient-led network of the people living with or affected by HIV in European region. This year we celebrate 30 years. It's 150 members from 45 countries in Europe. When we say Europe, we say Europe is including Eastern Europe and Central Asia region. So we mean kind of WHO European region. And EATG advocates for the rights and interests of people living with or affected by HIV and related co-infections within the region, and represents the diversity of more than 2.3 million of people living with HIV in Europe, as well as those affected by and or living with co-infections. Also, EATG is the organization who first ever developed and implemented the aging and HIV project from 2016-2018, and this is indeed our one of the priorities and the focus of the work of the network. And Mario, please, floor is yours.
Okay, I'll take it over from there. Thank you, Anton. Hi, everyone. My name is Mario Cascio. I come from Italy, and I am currently the program chair for quality of life of the European AIDS Treatment Group. Well, many of you have probably already read the Glasgow Manifesto, but many others didn't have the chance to take a look at it yet. Here, I wanted to talk about the rationale behind this call to action and highlight some of the key points contained in the manifesto. Well, let's start with this first question, why? Well, following the experience of the Silver Zone at the Global Village in Montreal at AIDS 2022, which was the first ever in-person networking zone for older people living with HIV, a group of us decided that it was time to give voice to the often neglected needs of aging and older people living with HIV. And this is how the iCOPe HIV initiative started. We felt that the challenges that many of us face in our daily lives are not well acknowledged, and our needs are not assessed by our peers living with HIV, by our community-based organizations, by our healthcare teams, by our government officials, and by global leaders in the HIV response. And we are a silent majority. All global estimates indicate that in the near future, the majority of people with HIV will be over the age of 50, with a big and increasing proportion over the age of 65. We felt that it was time to speak up. The HIV response and HIV care models have not evolved with us, and we feel we have been left behind. Next slide. Well, this is the rationale behind our call to action contained in the manifesto, because we feel that if we don't take action now, many lives will be lost, and many will be left struggling in their daily lives, coping with multimorbidity, along with other health conditions such as frailty, disability, chronic pain, chronic loss of energy, sleep disorders, cognitive impairment, depression, social isolation, and loneliness, and further experiencing ageism in addition to HIV stigma and other intersecting forms of stigma and discrimination. Next slide. At the HIV Glasgow conference last October, during a session organized by the European AIDS Treatment Group that was entitled Aging with HIV, From Knowledge to Action, the Glasgow Manifesto was officially launched. As a person who has been living with HIV for over 40 years now, I was pleased and honored to be the one reading out the manifesto. It was like speaking to the world about us, giving voice to the great number of older people living with HIV worldwide, struggling in their daily lives and often feeling neglected. As of today, we have received over 125 endorsements from organizations and institutions from all over the world, which shows the great interest on the issues highlighted in the manifesto and on the urgency of action needed. In the manifesto, we called on healthcare providers, on researchers, on community-based HIV organizations, on frontline providers of aging-related services, and on policy and decision makers to work in partnership with us to fund and implement these calls to action. Next slide. You'll find a link to the updated version of the manifesto in the invitation to this webinar. Here, I will mention a few key points from our call to action. The fact that we need to work together to develop new models of care for people aging with HIV, which are able to address the health and social complexities that we experience, including our sexual and mental health needs. As mentioned before, our current models of HIV care are not fit to respond to our clinical and social support needs. That we need a better understanding from our service providers of our distinct clinical and social needs. This should translate into better communication, better collaboration, joint priority setting, and joint decision-making. That we need responses from our community, which are age-affirming, addressing ageism and increasing intergenerational understanding. Ageism is present in society at large. In the case of older people with HIV, it's an additional burden often experienced within your same community. This is why intergenerational dialogue of people with HIV can address ageism, enabling a better understanding of common challenges and specific age-related issues. We call on policymakers to respond to the needs of older adults who struggle to afford adequate housing, food, and other resources for health because of their HIV-related disabilities. Because it's not all about clinical care and psychological support. Life can be miserable if you don't have decent housing and money to buy essential medicines and food. We feel there is a need for more targeted research and education on HIV in aging and older adults. This should be done with the active involvement of community, and it should respond to our community-identified priorities. We call for meaningful involvement, that people aging with HIV should be included in decision-making about the HIV response, including priority and target setting, funding allocation, and messaging about the impact of HIV on aging and older adults. Nothing about us without us. And above all, we all deserve age-friendly and age-affirming information, care, services, and support that considers not only the impact of our HIV status, but also our gender identity, our sexual orientation, race, and ethnicity, among other factors. Next slide. I conclude saying that older people living with HIV can no longer be ignored and must not be left behind. They are once again experiencing the uncertainties of the future, just like in the old days. Thank you.
Thank you, Mario, for summing up the Glasgow Manifesto, the first joint initiative of iCOPE HIV. We're now going to take a little world tour to hear from stakeholders in different regions regarding the most pressing needs of older people living with HIV, and to share examples of some of the initiatives that may already be in place to address these needs. We asked each of our speakers to reflect on these three questions when preparing their remarks today. What does it mean to age with HIV in your region? What are the key issues facing older people living with HIV in your region? What initiatives are in place in your region, if any, to address these issues? I want to introduce our first speaker, who will be Dr. Luciana Spadaccini, a researcher at Fundación HUSPED in Argentina, who will speak about the issues facing older people with HIV in Latin America. Sorry, I mispronounced.
It's okay. Thank you very much, Shubul. Thank you for the invitation. I wanted to tell you that I work in Fundación HUSPED, and it's a non-profit organization that works in regarding the research in HIV, STIs, and other infectious diseases, but also has a lot of work to prevention and prevent stigmatizing situations and to fight for the rights of the minorities. And before starting to talk about HIV in our region, I would like to put you in context that Argentina is in Latin America, and there are several aspects that affects the response toward HIV in Latin America. And one of them is the Gini index. The Gini index is an index that reflects the wealth and the economic income in the region. So it goes from 0 to 1. 0 meaning that all the residents in the country more or less has the same income, and 1 meaning that one resident has a high income and another resident has a really low income or no income at all. So when you have a Gini index that is near 1, there is showing a high inequality in the wealth and the economic factors in the region. And Latin America has the higher Gini index in the region. So it's really difficult sometimes to give a proper health attention in this context. And since 2020, post the COVID pandemic, the poverty and the Gini index increases. According to an AIDS, in 2021, 2.2 million people were living with HIV, and the new HIV infections mainly happen in young people, but as you see when, next please, Kate. The other one. 5% of the men that are older than 50, the new infections happen among them. And the new infections occur in 2% of the women that are older 50. So that's something to have in consideration. Next, please. The situation in Argentina is that 140,800 people live with HIV. The infection is more prevalent in men than in women, and we have around 5,300 new infections per year. Next, please. And next. And next. And here we see, before, please. Here we see that like about 2% of the new infections happens in people from 60 to 64, and 1% of the new infections occur among people from 55 to 59. But these new infections occur mainly in cisgender heterosexual men. Next, please. Next. And see, now we see here that the late diagnosis increases with age. You can see that in cisgender men, when the diagnosis occurs beyond 60 years, half of the diagnosis is a late diagnosis. So people are with low CD4 and with advanced disease. And this shows that older people are not getting tested because the physician may mistake the symptoms of aging with the symptoms of HIV. Perhaps the patient is ashamed or afraid of asking for the test. And sometimes people assume that other people are not at risk, so they don't ask for a test. And all those situations may this situation happen. Late diagnosis increases with age. And another situation in Argentina is that 2/3 of the people living with HIV assist to the public health system. And 14% of the people living with HIV are older, are more than 60 years. And the state pension in Argentina, the basic state pension in Argentina, is below the line of poverty. So we have older people living with HIV with no income, and this is also the situation in our country. This is the data we have, but we are lacking a lot of data, as you previously mentioned. So we started a trial in Latin America with CasaNet. CasaNet is the Caribbean, Central, and South America network for HIV epidemiology. And we are aiming to get 200 people living with HIV that are older than 50 years to see the things that we don't know now. For example, what antiretroviral therapy are they receiving? What is the viral load, the CD4 count, the comorbidities, the frailty, and the neuropsychiatric syndromes that affect them. We think that when we get this info, we will improve our way to give them a better health system and a better quality of life. Thank you.
Thank you very much, Dr. Spadaccini. Our next speaker will be Brent Allen. Brent is joining us today from the Australasian Society for HIV, Viral Hepatitis, and Sexual Health Medicine in Australia. We especially appreciate you being with us tonight, Brent, as it's currently about 2 a.m. over there. Over to you, Brent.
I'm delighted to join you this morning. I'm not really sure. I think we're right in the middle of it. I'm joining you from Dajurung lands of the Kulin Nation, just north of Naarm or Melbourne in Australia. I want to pay my respects to the traditional owners of the land and just acknowledge that sovereignty was never ceded. I also want to pay my respects to people living with HIV, those that are with us here today, those who are no longer with us. It's because of the lives of people living with HIV and our continued participation in research and programming that we're here today, alive and well, and able to do this work. I can acknowledge that I've been living with HIV for almost half my life. I've just turned a glorious 54 years of age. And in terms of what it means to be living with HIV in Australia, and I want to respect the fact that we are in a very diverse region in the Asia-Pacific region, and to acknowledge what Jules said, the Asia-Pacific region has quadrupled their number of people over the age of 50. It's a fast-growing epidemic in this region, and it's growing in terms of its complexity, and older people are part of that. What it means to live with HIV in Australia is very much like what it means, I think, for many people around the world. We face the double stigmas of aging and having HIV. I think that there are the issues of polypharmacy, of comorbidities, of navigating health and social service systems that can be complex. I wanted to point out something, though, that I think in my mind, is a powerful issue around aging with HIV, and that is loneliness. I don't believe it is an existential issue. It is a health issue, and it's a crisis in our community, and it's a crisis worldwide. People who are lonely get sick faster and more often. It is just that simple. And people who are older, people who are living with chronic illness, are experiencing loneliness faster than anyone in the world. One of the issues I really want to point out to everyone, and I'm sorry I don't have slides on this, I will, however, put links into the chat. One of the things we've been doing over the past year in Australia is talking to people living with HIV. We've talked to several hundred people, and we've developed a report, an analysis that we're calling AusQual. AusQual looks at the synthesis of these dialogues amongst people living with HIV. And we've identified 4 positive variables that positively influence someone's quality of life, and 4 variables that negatively influence. The 4 variables, and this is for all ages, that positively affect your quality of life are meaning, belonging, care, and support. Those 4 that are profoundly negative on people are isolation, stigma, distress, and insecurity. Again, I'll send you the link to this because I don't want to take up too much time showing you the detail. The other thing I want to point out to everyone, again, I'll send a link, is a PAUSQUAL scale. The PAUSQUAL scale is developed here in Australia. It's 13 questions. We have a movement going on in Australia at the moment around people living with HIV that we're going to take the AusQual scale, the first of every month for the next year, and then see how quality of life changes using a similar scale over time. This is something we're doing as a community-based research program amongst those of us living with HIV. I think it's a powerful way that we can demonstrate how our quality of life changes and link it back to our quality of care. The fabulous Limin Mao, who's also here from Australia, has already put the links into the chat. It's, I think, a powerful way for us as individuals to track our own healthcare and our own quality of life, understanding that quality of life, I believe, should be the fourth 90 or 95 that underpins the rest of the cascade. Without a quality of life, we don't get people testing, we don't get people treating, and we lose them to care. The last thing I really want to point out is the power of peer navigation. I was in Montreal at a high-level meeting around patient-centered care, and I want to point out to you that, you know, lots of the clinicians who were in that meeting with me felt that peer navigation was nice, but not necessary, that it was not nearly as necessary as the clinical care that's provided. And I would like to challenge that. I believe that us connecting with our peers to help us navigate complex health and social systems is critical. And we have to invest higher amounts of money in ensuring that peer navigators are used across the board. I'm delighted to join you, and we'll be here for the rest of this discussion. Doubt I'll go back to sleep after this. I have had 4 cups of coffee, but let's see how it goes. Thank you very much for listening.
Thank you very much, Brent, for painting a picture of what life is like for aging and older people living with HIV in Australasia. Next, I'll turn the microphone over to Anton, who you've already met, to discuss the situation in the Eastern Europe and Central Asia region.
Yeah, thanks, Jules. So, yeah, next slide. Oh, yeah, it's no, sorry, please. Yeah, so I introduced myself, but if you want to know more about who is actually Anton Bosenko, you can just Google Anton Bosenko and you will have lots of different information publication. Next slide, please. So, as I mentioned, I'm from Ukraine, from Eastern Europe, Central Asian region, which is the region with the fastest growing HIV epidemic in the world, the region where 1.56 million people are living with HIV, 70% of which are placed in or living in Russia, and around 140,000 are newly infected each year, with 43% increase in new infections between 2010 and 2020, 30% increase in mortality, and with concentrated epidemic, because 90% of new infections among key populations where people who inject drugs and their sexual partners have 45% of HIV infections from total 90 of all key populations in the region. It's important to say that the region is quite heterogeneous. Of course, the Russian Federation has the biggest contribution to HIV incidents, but size is not the point. Ukraine is the second most populous country in the region, and though we are quite successful in stabilizing the epidemic and containing the epidemic among people who inject drugs, we have the largest harm reduction and opioid substitution therapy program in the Eastern region, Eastern European Central Asian region, but still Ukraine accounts for 10% of new infections. And on the right part of the slide, you can actually see this distribution between countries of the region. And of course, the gray color is Russian Federation, and the kind of a pink color, I think it's Ukraine. So you can see that it's the most meaningful part of these circles. Across the region, please step back. Across the region, major political, policy, legislative, cultural, and technical barriers prevent and delay people at risk from accessing prevention, whether it's a PrEP or self-testing or harm reduction, and from accessing treatment. Of course, stigma and discrimination, because we are talking about the region with, let's say, post-Soviet heritage with, quite repressive systems, or like stigma and discrimination to people who are not, let's say, who are considered as not normal. That's why it's definitely one of the key barriers, as well as we have to say that besides Baltic states and Russian Federation, all other states of the region are countries with low and middle income. That's why, of course, it implies the quality of medical health systems, infrastructure, and things like that. Next slide, please. This is very interesting slide with the age distribution of newly registered HIV cases in Eastern Europe and Central Asia, where you can actually see that the biggest growth of newly registered HIV is in, like, visually it looks like it's in cohort of people 30-39 or 40-49, but if we're talking about proportionally, in comparison of 2017 to 2010 or 2015, you will find that the biggest growth is in the cohort of people 50 plus. Next slide. What else do we know about aging and HIV from data in the region? Actually, nothing. I mean, if you Google or if you try to find like some separate, slides with the regional scope of the issue or data on aging, you will not find anything. Of course, if you have deep dive to country data of certain, I don't know, Republican aid centers or monitoring centers on HIV, some pieces of like information can be found, but still it's information rather standard thing like prevalence, incidence, new cases, but there are no even special like monitoring or evaluation criteria or let's say indicators which are under special control from the M&E specialist. Next slide, please. We, of course, we all know that it's better to have some goals when you try to fight with things like HIV or doing any kind of advocacy, and we of course respect these 90-90-90 goals, because as a community representative, I'm personally was also part of consultations when these global goals were on the development. But I have to admit that unfortunately for at least in my region, for countries in my region and for medical systems in my region, 90-90-90 turned to a real paradigm of thinking. What I mean is that first of all countries of the region are Global Fund implementers and mostly, or not mostly, but some part of it, PEPFAR funds implementers. And of course, all these HIV projects or big programs or even national programs, they are so strictly based on this framework of 90-90-90, like to know your status, what is about kind of testing and 90% on treatment, and 90% of those viral load suppressed, that all activities and all work of, if we're talking about special, healthcare facilities, it's really strictly framed within this paradigm of thinking. And once the person living with HIV viral load suppressed, it's kind of the end of the interest to him, and there is no special questioning of what's happening after, but because you keep aging with HIV and maybe you have another issues. But no, I mean, just good luck and bye-bye, and please come in a new positive patient from the test. So that's unfortunately how it looks like. And sorry, Kate, yeah, but anyway, talking about the reaching these goals, the reality is that this region didn't meet the 90-90-90 goals till 2020. So there is a still risk that we will meet 95-95-95 goal in 2025. You can see that the biggest gap in this cascade is last two thing, people on ART and people with viral load suppressed. In blue, you can find the Eastern Europe, Central Asia region. Next, please. And as I said, I'm a person who use drugs, and why it's important to mention people who use drugs and this scope of issues about the region, because as I mentioned, drug use accounts for around 50% of new infection in the region, though unprotected sex is set to become the main driver in the coming years as well. And 1 in 7 people who inject drugs is living with HIV, and 1 in 3 is infected with hepatitis C, what is one of the most widespread or well-known co-infections or comorbidities. And that's another thing which also creates the issue for people aging or older people living with HIV, if they are also aging or older people who use drugs, because living with hepatitis C and really low access to hep C treatment in the region creates additional pressure on your health, of course, or creates additional risks, as well as we're talking about other, let's say, specific things, not just like health issues like for person living with HIV, but for instance, if you are a person who uses drugs and you are many years on methadone or buprenorphine treatment, sometimes like after 15, 20 years of taking ART and OAT medications, it's an issue of polypharmacy, or it's a number of additional things which you have to keep in mind talking about my region. And the region is home to an estimated 3.57 million people who use drugs. That is actually a quarter of all people who inject drugs worldwide. And last point is that, unfortunately, access to harm reduction and health services remains limited. And in the reality where there are no specific clinics for older or aging people living with HIV, and in existing clinics, there are no specific let's say, programs or attention to these issues. If you add also low access to harm reduction programs, which is a kind of gate or opening the gate or access to further cascade of access to healthcare facility and other parts of medical system, that creates a huge problem. Thanks for your attention. And yeah, Jules, floor is yours.
Sorry. Thank you, Anton. Did you have something did I cut you off?
No, just passing you.
Okay. Thank you, Anton, very much. I'm now going to share some information on issues affecting older people living with HIV in the US. So this is just highlighting the demographics, the so-called epidemiology of HIV in the United States. Oh, if you look at the bars on the right, the panels on the right, well over 200,000 people are over 60 already. In New York City, 30% are over 60, 50% will probably be over 60 by 2030. In San Francisco, similar numbers. It's expected in the United States by 2030 that 70% will be over 50. And right now, 50% are over 50. What does it mean to age with HIV in your region? Many older people with HIV, particularly the elderly over 65, are suffering accelerated or premature aging by 10 or more years. Many of us live with more comorbidities, and the burden increases as we age. We are at increasing risk for premature death, mortality, reduced survival, worse quality of life, worse physical function, inability to perform normal daily activities like food shopping, food preparation, using transportation, communication with our doctors, frailty, we're at increased risk for cognitive impairment and brain fog, and becoming disabled and being put in long-term care facilities. For many, the quality of life is horrible. So what are some of the key issues that data has been published about people aging with HIV in the United States? Well, this was a published study about people on Medicare, people over 65, and as pointed out in the chat, some people on Medicare are not over 65, but are disabled. And you see double the rates of comorbidities, hypertension, hyperlipidemia, that's cholesterol, triglycerides, heart disease, double the rates, diabetes, number of chronic conditions, 8 times the risk versus people without HIV for having 5 or more comorbidities, all in the panel on the far right. What are some of the key issues facing older people? Well, cognitive impairment does not get enough discussion. Studies suggest that about 45% of people in the United States suffer cognitive impairment. 33% so-called asymptomatic cognitive impairment. That means they may not realize that they have it, excuse me, but upon testing, it's found. And 12% with mild neurocognitive impairment that they may realize they have. That doesn't mean people are unable to function. Many people are still able to function, but still have cognitive impairment or brain fog. And some people, it affects their functioning. And a small number of people experience dementia at a higher rate than people without HIV. Also, a very large published study, also in Medicare, found African Americans and Latinos have 3 to 4 times higher rates of comorbidities. And people with HIV had 7 times higher rates of 5 or more comorbidities. So that is one of the unique aspects of aging with HIV in the United States, that it impacts disproportionately African Americans and Latinos with 3 to 4 times higher rates of comorbidities. Another unique aspect of studies showing in the United States, but also probably globally, is that there's a disproportionate effect of aging and comorbidities on women versus men. And you could see on the left, the dark blue, as women age compared to HIV negative women, the increase in the numbers of comorbidities. And on the right, you see as they age compared to HIV negative women, in the large WISE study of women with HIV, the numbers of comorbidities is more than women without HIV, and also increasing at a worrisome rate. And studies do show that women with HIV experience more comorbidities than men with HIV. This highlights some of the aspects of aging with HIV on a geographic basis in the United States. You can see the dark brown states in the United States where there are more people with HIV who are over 50. And you see that there's a predominance in the southern states. There's an issue around the US rural South. So people, not just in the US, but globally, who live in rural areas will suffer disproportionately from, excuse me, from dealing with accessing the healthcare system and experiencing comorbidities. People who live in rural areas will have more trouble with accessing the healthcare system. And you can see which states have higher prevalence of people with over 50. It includes California, it includes the Northeast, but it includes most of the southern states. So what do we mean by people have trouble with inability to perform normal daily activities of living? This was a study of people who were only 50 years old, not 65, but 50, but listing the specific types of impairments they experience. Difficulty in housekeeping, transportation. That means getting on a bus, getting from one place to another, shopping, doing the laundry, keeping their finances, paying their bills, excuse me, doing their cooking. Difficulty actually in using the phone. That is true. And difficulty with managing their medications, adherence, and polypharmacy. So what's going on in the United States? What initiatives do we have uniquely to place to address these issues? Well, there are 23 new HIV aging clinics recently funded and started in the US as demonstration projects that will be providing geriatric elder screenings, care, mental health, and social support services. Just last month or 2 months ago, New York State announced 10 new HIV aging clinics to the tune of $20 million over 5 years. New York City, 2 years ago, announced 3 similar clinics. And nationally, our national government announced last year 10 such clinics at 10 sites in 10 different cities around the country for $10 million for 3 years. These are demonstration projects, but 95% of people who are over 60, which is over 200,000 people in the US, are not receiving access to these services. These new aging HIV clinics will serve a small number of people as demonstration projects but lots of other people over 65 or suffering from comorbidities will not have access necessarily to these services. So what are the initiatives not in place? What are the gaps? What are the needs? Well, the HIV healthcare system all over does not address these problems. Elder and geriatric screenings are not roundly being done. Access to medications for the elderly, like statins and other drugs for older people, and insulin may not be available in poor countries like Africa or India or other parts of the world. We need better care. We need funding to support healthcare change to ensure that our healthcare systems meets these needs. We need mental health care services. We need more education. Older people with HIV need to understand aging and comorbidities. We need a better quality of life. In the United States, very often, the general healthcare system provides to people without HIV routinely elder care and geriatric screenings, which we don't get in HIV. People who get care through the Obamacare or the American Care Act get these kinds of screenings very often. Falls prevention, etc., screening for frailty, we don't get it. And access to medications outside the US, that I list some of them here, may not be available in some parts of the world that we have here in the United States. Like I said, statins or drugs for kidney disease and for diabetes and Fosamax for bone disease. Just recently, the International AIDS Society in the United States issued these guidelines recommending all people over 50 be screened for comorbidities, impaired cognitive function, poor mobility, frailty, falls risk. We're not receiving that. With that summary of the US done, I'd now like to invite Sheba Burrell Atbam, Regional Coordinator for the Asia Pacific Network of People Living with HIV, located in Thailand, to tell us more about the Asia Pacific region.
Yeah, thank you, Jules. And we are not very different from other regions. So what I'm going to talk about is probably, previous speakers already have said, but, please bear with me. I'm going to repeat a lot. We don't have any initiatives in this region as far as we know, dealing with all the people living with HIV. And APN plus the organization I work for, which is a regional network for people living with HIV, we try to do some research with people living longer. We call it living longer. That was in 2014, about nearly 10 years ago. We had a very quick assessment with people living with HIV, more than 10 years. So it wasn't really an older elderly or older people. But we found a lot of similarities though, like isolation, for example, depression, and fed up with taking pills, that sort of things as well. And as the previous speakers have said, we see so many people, 50 people, 50 years now in this region, and it's hugely increasing during the last 3-4 years. Probably that is because in the past we didn't really try to look at these particular age groups. That's why we were not aware of what's going on. But during the last 3-4 years, probably that's because of some of us are now more than 50 years, and some of the people we know, we have been working with, they are older, elderly people. So because of people we know who are more than 50 or elderly people, 65 plus, we started looking at these issues during the last 3-4 years, and the issues, when we talk to these people in a very informal way, we found very similarities. Like illness is a non-HIV related. It could be HIV related, but so for example, liver problems. We see so many people with liver problems, and a lot of them are also ex-users as well, ex-drug users. And the kidney problem, diabetic issues has been increased a lot as well, and the hypertension, heart problems. And the access to these services is a huge problems. So in Asia, many countries don't have a free healthcare program. Very few countries like Thailand, a few years ago, government started free healthcare program. But other than these few countries, majority of the countries in this region do not have a free healthcare program. So people have to pay themselves out of pocket. So access to these services is a huge problem, and a lot of them are already having financial issues, financial crisis as well. Income is a big problem in this age group, and some of them work in the past when they were healthy or had the energy to work, but now they are becoming older, so they can't do the same work they used to do in the past. So that basically impacts on the income. So that basically impacts on everything in life. The access to even daily essentials like food is becoming a problem for a lot of them as well. And mental health is a big problem, as you also previous speakers have said. Isolation, depression. And then if you are depressed, then obviously you can't sleep. So you have the insomnia, or whatever the term we use for the sleep problem, is a problem as well. And the finding new job is a lot of people try to find new jobs, but we keep hearing that but we are older and nobody want to give us job. So they have to go to somewhere they know that they expect that they would get offers, they would get a job, but that's sort of places are very few. So getting new job or finding a place where they can get some income is becoming a big problem as well. Yeah. So and then maintaining relationship is also it comes from some of them as well. A lot of them are having problems keeping or maintaining the relationship they have with their partners. And we don't know the details though yet, but their partners becoming fed up, or they becoming fed up with their partner, or whatever the reason, that maintaining the relationship is also a problem for some of them as well. So we hear this from time to time when we speak to some of them in an informal way. And then for those like family men, for example, having kids, and they also have a lot of worries as well about the future of their kids. What would happen if I pass away? And then what would happen if my kids' friends find out that their father is a HIV positive person, then what sort of like impact it can have on their kids, what sort of like pressure their kids can get from their friends. There's sort of like worries also we hear as well. Yeah, so yes. And the only positive thing we hear is, I would say this is one of the positive things. And some of the elderly people or older people have been working in HIV as well. And when they see, newly diagnosed people, those newly people get a lot of inspiration when they see a person living, living with HIV, 60 plus years old. And because the newly diagnosed people, they initially thought they are going to die soon, but when they suddenly see a person, a 60-year-old person, they get a lot of inspiration. So that's sort of like, good things also we hear. So that's a good thing for working in the field. I would put that way. So I won't take so much time. So the issues is very similar, as I said earlier. And I would finally, I would say again that there is no initiatives to deal with this age group across the region as far as we know. But this is a huge, growing, problem in Asia Pacific, and we have to continue pushing services for these as well. So thank you so much. I would end here.
Thank you so much, Sheba. I'm going to jump in for a moment, Jules, just to say that as we're running behind on time, Mario, who was going to present on Western Europe, and myself, who is going to present on Canada, are going to skip our portions of the presentation. You will have the slide decks.
Yeah.
And we can always revisit these slides afterwards, but I do want to give time to our guest speaker, Albertina, who's joining us from Eswatini. So Albertina, over to you.
Hello, everyone. My name is Albertina Nyatsi, and I'm from Eswatini. I work for an organization of women living with HIV called Positive Women Together in Action. Eswatini is a small kingdom in Southern Africa, which shares borders with South Africa and Mozambique. It is a country with a population of about 1 million, 1.2 million, and we're a country that loves our culture. We're so cultural. And then looking at aging, it's like aging doesn't feature anywhere when you talk about HIV. Even when you go to the clinics, there is nothing specific about aging. There is nothing that talks about aging with HIV. It's just like a one size fits all information. If there's something that is being done, it's a small portion, but it's not even written anywhere. There's nothing about aging. So what does aging means in Eswatini? In Eswatini, aging with HIV is not easy. Life is deteriorating, and you feel neglected at home, community, and even at the health center. Because even when you can go there and say you are sick, especially if you are old, you want to be taken care of, you want to be examined. But in most cases, just because you are old, it is assumed that the reason why you are sick is just because you are old. So there is nothing much that is done to look into what is it that is ailing you. And then we come to what aging means in Eswatini. In Eswatini, aging with HIV means like less opportunities, as most opportunities are for those who are 18 to 35 years old. When you look for opportunities, if you're above 18, it then becomes difficult. Also, there is high catastrophic cost to care for several diseases. in one body, because once you get you age with HIV, you start having co-infection, you start having NCDs, diseases like osteoporosis, eye problems, joint, and etc. So you'll be using a lot of money to take care of those diseases. And then also for some, it means disability due to NCDs and a weak immune system due to aging. We've got some people that as they age, they're now disabled because their immune system is getting weaker and weaker. And then also it means having mental problems. So most people, they get PTSD, they get whatsoever types of mental problems that they start. Our children are now starting to tell us that we are speaking loudly, we are shouting, and then we are isolating ourselves. And also, it also means being judged for sexual choices. As you get old, people start to judge you, especially it's like as you get old, you should be less sexually active. So if you get sexually active, you get questions like, why are you getting in a relationship when you are old and HIV positive? They tell you, you know yourself, you are sick, so now you want to kill yourself because you know you're sick. And also, if you are in a relationship, you are old, you want to kill him with your HIV, or you are sick because you have sex and yet you know you are positive. And to think that you are having sex at this age. So it's like once you are HIV, you are old and HIV positive, you should start refraining from sex. And if you do engage in sexual activities, it's like someone should tell you what to do and what not to do. And then the initiatives that are in place, we've got the 3-month dispensing of NCD medication like ART, which means now NCD medication is dispensed like ART, and then you are given for 3 months. We've got regular testing for NCDs. So as you go to the hospital, they have started to test all those who are from 40 to 50 for NCDs. And then also, there is a KY gel that is available for those who have problems with sex. But the other problem with this KY gel is that it is not there for everyone to see. It's like you have to ask for it. And then most people are even scared to ask for it because they will be seen as like having sex. And then also there is a little bit of psychosocial support and therapy if you go to certain hospitals. But most hospitals in the communities, there's nothing. And then the priority interventions with HIV and aging in Swaziland, we needed to ensure availability of HIV aging SRH affirming services. Because as we age, we still engage in sexual activities. We need to be assisted so that we can do sex successfully. Also, it's like we also need certain services, like as you grow up, you find that some people doesn't have children. And when we are still young, you are told that you'll be able to have this and these things that are going to assist you with having children. But when you start asking for those services, you find that they are not available. And then also prevention of stockouts, as sometimes for NCDs and other diseases, people have to buy at the chemist. And as you are old, you are jobless, sometimes you don't have money to go to the chemist. Also, there is we need the provision of food parcels for old people living with HIV, because nutrition is important and we no longer working, or we're no longer able to go to the farms and farm food for ourselves. And then national regulation and guidelines for inclusive care for older people living with HIV. Okay, we need national guidelines and regulations that are going to talk about people that are aging with HIV for inclusive care of us, and also inclusive care for us as we continue to age and we need care with HIV. And we need these things written down, and we need these things being used so that we are helped. Okay, ladies and gentlemen, thank you very much.
Okay, so do you want to take us from here to what's your suggestion?
Absolutely. So we're going to go to Axel, who's just going to finish up by providing some of our proposed vision and objectives so that we make sure we get that in before we lose everybody.
Okay, thus the iCOPe HIV vision, which is outlined in detail in the Glasgow Manifesto, is improved care, optimal quality of life, and empowerment for aging and elderly people living with HIV globally. We will work towards making this vision a reality by achieving 4 objectives proposed in the next slide. Please keep in mind that this model has not been set in stone. It's a proposal subject to your input and feedback. With that said, I will review quickly the objectives and proposed activities now. 3 of iCOPE's HIV proposed objectives relate directly to the themes of the Glasgow Manifesto: care, quality of life, empowerment. With respect to care, we want to increase the capacity of decision makers to implement models of care for us, all the people with HIV. In order to document these models of care, we have to identify them and learn from those involved what is working well and where gaps still exist. We will propose to conduct an environmental scan, literature review, and key interviews to document best promising practices. We will mobilize the information to produce an advocacy tool we and others can use in their interactions with health systems administrators and policymakers. All these decisions should be evidence-based. With respect to quality of life, our objective is to document priority issues affecting the quality of life of us around the world, as well as initiatives that are in place to respond to these issues. This webinar, including the polling questions we are going to ask you in a moment, is a first step toward achieving this objective. Moving forward, we propose to conduct a global survey with organizations serving all the people with HIV to gather more detailed information on quality of life issues. And we will then produce a survey report describing our key findings and recommendations. With respect to empowerment, our objective is to increase knowledge of age-related health conditions, geriatric syndromes, and prevention and management strategies among older persons with HIV. To this end, we propose to identify priority topics for webinars with iCOPE member organizations, engage experts, and conduct and evaluate educational webinars on topics relevant to older people with HIV. And then finally, as 4th objective, which is process-oriented or internal kitchen, it relates to building the capacity of iCOPE's HIV network to respond to issues related to HIV and aging. In order to do this well, we recognize that we need more people involved who bring different perspectives. We plan to recruit a steering committee made up of stakeholders from around the world, paying attention to equity, diversity, and inclusion. We will create then terms of reference to guide our work so that our decision-making processes and plans are transparent to all of you as stakeholders. We will communicate regularly with the membership to share information and opportunities for engagement. And one of our first talks will be an infographic version of the Glasgow Manifesto, which we will translate in languages other than English. And finally, and not least, in order to make all this happen, we need resources: person, power, time, and materials. And one of our first items of business will be to secure some funding to establish iCOPE HIV Secretariat. I'm now going to turn the microphone again to Kate, who's going to conduct some polls with you about these priorities. And we are eager to hear your input.
Thank you. So realizing that we're running out of time, I am just going to launch one poll, which we think is most important, which is to understand from you which of the iCOPE priorities are most important to you. So if you can't see the whole priority that shows up on the screen, you can hover over the text and you'll see the remainder of the text. It seems to be cut off if the window is too small. So please take a moment to vote, and I will share the results of the poll at the end. All right. I'm going to give people about 10 more seconds to respond. Okay. Thanks, everybody. So interestingly, almost equal priority or almost equal emphasis on all three priorities, basically split 33, 31, 36%. So that's very interesting. Hopefully that means that we're on the right track. We do have some more polls questions to ask you, but perhaps we'll ask you them in a follow-up survey. I'm going to turn things over to Jules to just tell you about some of our next steps and to wrap us up for the day. Jules, are you there?
Yes.
Okay.
Thank you. Thank you all for participating very much. Thank you all very much for all your comments and suggestions in the chat. I have looked through the chat and we will look through the chat and collect your comments, and many of them are so on target, and we appreciate that. I want to thank all the organizations that have endorsed the Glasgow Manifesto, and I want a special thanks give to all our guest presenters, Dr. Luciana Spadaccini, Brent Allen, Sheba, and Albertini. And that brings us to the end of today's webinar. I'd like to close by acknowledging all the organizations again that have endorsed the Glasgow Manifesto so far, and the staff at Realize who are working behind the scenes to provide the tech support for this event. And I want to tell you that we will be in touch. We hope and plan to help all the organizations and people living with HIV globally to address this very difficult problem of aging with HIV around health, quality of life, and simply being able to cope with aging and being elderly with HIV. Thank you all very much for being here today, and we look forward to speaking again soon.
Slow green.
Thank you, everyone. Bye-bye.
Thanks.
you.